We have a program called Careguard 360. Careguard 360 is when we come in on a monthly basis and we literally look at the patient head to toe, side to side, look at their feet. We're getting their blood and their urine and doing all the things that are needed for that patient. And we want to take a look at them. We want to make sure they haven't developed bed sores. We want to make sure that their epidermis isn't breaking down. We want to make sure that they're not getting pressure sores. We want to make sure that they have adequacy in blood supply to their skin and that they're not having issues. It's really hard for patients to get that kind of analysis because usually the caregiver is just trying to get from point A to point B, and they may not necessarily be trying to get the patient up and looking all the way around them. And what we're trying to do is we're trying to analyze it to make sure that things aren't breaking down, that there aren't red marks that are hidden, that are underneath clothing that are resulting in bed sores eventually. Because if they get a bed sore or they get an infection, it's a bad thing from the facility standpoint. It's a bad thing from the standpoint of providing quality of care. And so the Careguard 360 program is to literally look 360 around that patient and to document any changes that we can notice. We're looking for wounding, bruising, ecchymosis, cuts, scrapes. We're doing pictures, and we're putting together all of that information in a comprehensive package so that it's a piece of data gets retained, and that information is then fed to the physician for that patient, to the caregiver for that patient, so that they know what's going on. And it also gives the family a good feeling that someone is really paying extra attention. And if something has been identified and we've identified it early, it makes it much less likely that someone's going to get upset because, things happen. We know that. Everybody knows that. That's the nature of human beings. It's the nature of getting older. It's the nature of being in a facility. But it doesn't have to be the nature of litigation. And that's what we want to avoid. At the same time as we do this, you can't do this by telemed. You have to actually be in front of the patient. You have to smell the patient. It's a sniff test. You're going to smell things on patients that are not visible by photograph. You're going to smell things that are invisible until you're right next to the patient. You might be smelling Pseudomonas. You might be smelling something totally sweet that is an infection. You might be smelling a fungus. These are all things that are important. You might be smelling phenolic compounds because somebody is not cleaning the bed as well as they should. Or maybe there's debris or detritus in a corner of a room, and it's obvious when you get in there, but it's not obvious unless you're in there. And there's no way that the ownership group is going to go to every single room, every single patient, every single month, and look at every single patient. So that's the issue. There's no way that management and ownership does that, and they can't. We can, because we're going in to look at those patients and collect their blood samples and collect their urine, and we can do this simultaneously. It only takes us an extra 3.5 or 4 minutes, but it's well worthwhile because we're going to easily identify issues that were left unidentified, and it really improves the quality of your outcome because we're able to feed this information to your providers who can then address it from a medical standpoint. So it's visualization, it's a sniff test, it's photographic evidence, and it's sampling of blood, urine, saliva. And we're going to look at those feet. That's the comprehensive picture of what Careguard 360 is. Now, beyond that, we have a Missouri protocol, and I've got videos on that are totally separate. But the point of Missouri is to measure the metabolic dysfunction of the patient and improve their outcome. It's a combination of early pathogen detection, therapeutic monitoring, pharmacogenomics. It's the outcome of how do we improve the metabolic health of the patient and reduce their insulin resistance. It's how do we maintain healthy muscle mass and reduce fat mass. It's more than just diet, it's lifestyle. And if the patient has issues, we identify them and engage them in a lifestyle coaching program. In the general population outside of the nursing home, 93% of people are metabolically ill. Inside a nursing home, 99% of patients are metabolically ill. And yet we don't even monitor those metabolic profiles on most patients. When we use the Missouri protocol, that's what we're monitoring. And we have specific protocols that help us figure that out. And they do generate revenue for the facility. And I can go through that at a separate time, and we have specific protocols. It's through Misura.ai, and it generates really good revenue for the facility as well as for the provider team. But the key element is Misura is integrated into our protocols so that we make sure that we get ahead of these situations. We're looking well beyond just paper. We're looking at compliance and diversion and metabolomics. We're monitoring everything about that patient. And we want to make sure that we maintain chain of custody when we collect our samples so that things don't get lost. So sometimes we do saliva instead of urine for toxicology because we know that we directly collected that sample and it's our people that are collecting the sample. And a lot of times patients, you try to get a urine sample for a urine tox, you may not be getting the right sample, or you might be picking up the sample and it might not be that patient's sample, or it might be contaminated. So those are all things that we worry about. And so chain of custody in Misura is really important, and making sure that we've directly examined that patient is really important. When we look at pathogen detection, we want to be very specific. We don't want people to get general antibiotics just because they think that they might have a urinary tract infection. You can certainly start there, but we want to be very specific and realize that the old method of urine and culture sensitivity, growing the bacteria, is inaccurate 30 to 45% of the time. And by the time that you get a CNS back, it might be 5 to 7 days. Whereas the PCR technology that we do, it's within 2 to 3 days. And those couple of days may be the difference between having a urinary tract infection and going on to urosepsis. And giving somebody a broad spectrum antibiotic rather than the specific antibiotic to treat the specific problem could be a problem. So that's what we're trying to get to. We're trying to make sure that we got the right treatment for the right patient at the right time. And we want to reduce the spread of the disease in the facility. Therapeutic monitoring is the concept of looking at the medications that the patient's supposed to be on. That's separate than toxicology. For example, we can pick up therapeutic monitoring for their beta blockers. We can pick it up for trazodone. We can pick it up even for their insulin. There are all kinds of ways that we can pick up what the patient has actually gotten versus what they should have gotten. If they don't have insulin level and they're supposed to be on insulin, but there's zero insulin, that's a problem. And we can measure that. And if they have a high C-peptide and they have a normal insulin level, it could be that they don't even need their insulin because their body's producing plenty. So there are subtleties in all of this stuff for therapeutic monitoring that we're really good at helping identify. And so it's outside of just looking at opiates. It's looking at a comprehensive picture of the other medications that the patient might be on to make sure that hypertensive crisis that you saw where they potentially could have had a stroke wasn't caused because somebody missed the dose of clonidine or they missed the dose of a beta blocker. Maybe the person thought that they were getting a pain medication, but they got ibuprofen instead, and that might explain why they're bleeding. So there's all kinds of things that happen in the background, and that's what therapeutic monitoring is there to help us identify through the Misura protocol. Pharmacogenomics is an emerging field where you put somebody on a medication and it doesn't work like it's supposed to, or let's say that you put them on a pain medication and the patient goes, I still have terrible pain. And yet on the therapeutic monitoring, it's in their system, but it's not working for them. Well, it may be because they have the wrong gene set, or maybe they're over metabolizing. It's really important when you're dealing with schizophrenia and chronic insomnia and anxiety disorders. It's really important when you're dealing with complicated issues to make sure that the medications that you're prescribing are appropriate for that specific patient. It didn't used to be a big deal 20 years ago, but the vast majority of patients that have pharmaceutical failure, it's because their genomics are a little bit different than everybody else's. And it could be almost half of the patients that you've got that may be having a pharmaceutical failure. There's also the concept of neurodegenerative changes. Let's say, for example, that your patient is at risk for Alzheimer's. Let's say that they're ApoE4 homozygous. If they are, that's a 95% chance that they may end up with Alzheimer's. If they end up with Alzheimer's, that really dramatically increases the risk of that patient becoming more and more deteriorated very, very quickly over time. Now, the cost of the Alzheimer's medication treatment options are about $80,000 to $90,000, and they have a 1% chance of improvement. Whereas if we identify that patient at risk with an ApoE4 homozygous, and we put them in a lifestyle coaching program, that's 40 to 60% effective. And the interesting thing is they still have the diagnosis, so the compensation model doesn't change that way, but the amount of effort that's required to take care of the patient dramatically improves because the patient has lifestyle management and coaching. And you get paid for lifestyle management and coaching separate from your facility fees. And so it allows you to get better care of the patient at a lower cost, at a lower pharmaceutical cost, and you've aligned your goals with the goals of the federal government. Save money where you can and improve the outcome, and at the same time, improve the patient's health span and improve their lifespan, which improves the length and duration that they're going to be in your facility, which is what you want. You want to help protect the health of the patient and maximize everything that you can to help that patient get better.